بذارید سلام همکاران عزیز، ما الان در حضور آقای دکتر اکارت رودیگر هستیم. ایشون چندین سال توی هیئت مدیره انجمن اسکیما تراپی بودن هستند و یکی از مدرسان این رشته هستند. ما خیلی خوشحالیم که در خدمتشون هستیم. از آلمان الان دارن صحبت میکنن و صحبتشون رو به انگلیسی انجام میدن. ترجمه هم نمیشه، برنامه هم ضبط میشه. فقط گفتم برای اطلاعتون بگم برنامه از چند دقیقه دیگه شروع میشه. بعد خواهش میکنم پس دیگه میکروفوناتونم ببندید، ویدیوها هم ببندید که بتونیم بعد از برنامه 5 دقیقه قبل از برنامه، یعنی از ساعت 11:25 تموم میکنن. بعد میتونید سوال کنید اگر که بخواید، ولی به انگلیسی. Ich habe auch gesagt, dass du da schon einfach auch dann 5 Minuten halb da schon einfach auch dann beendest und da können die da 5 Minuten einfach auch dann deren Frage beantwortet wissen,
Ja.
als sie da irgendeine Fragen haben. War das da?
Mhm.
Mhm. Ja, hast du eine PowerPoint-Präsentation?
Ja, klar. Genau,
Mhm.
habe ich. Ich stelle gerade nochmal die Kamera ein bisschen ein. Die kann noch ein bisschen weiter runter, glaube ich. Ups. Weil ich werde eventuell, genau, die Kamera nochmal wechseln. So. Das ist gut. Muss ich
Ich
alles
werde
noch ein bisschen.
wahrscheinlich dann ein bisschen abgelenkt sein, weil wir haben keine andere Host.
Ja,
Und dann werde ich wahrscheinlich dann ein bisschen abgelenkt sein mit der reinlassen.
ja, das ist völlig okay. Du signalisierst mir, wann ich anfangen soll.
Ja, ich sag's dir mal schon einfach.
Genau.
خانم نفیس، میتونید دوربینتون رو ببندید؟ ممنونتون میشه. Okay. Wir warten dann noch 1, 2 Minuten und dann
Mhm.
können wir loslegen.
Ja.
Ja.
Wir machen diese Blockkurse ja, weil viele auch dann von weiter weg kommen. Die fahren dann 2, 3 Stunden. Das ist dann kein Problem, wenn man einmal hin, einmal zurückfährt.
Ja.
Und die sind auch gut besucht. Also das ist
Ja.
tatsächlich, die Wochenendkurse sind immer schwieriger, aber die richtigen Kurse, also die Blockkurse laufen sehr gut.
Also, du kannst mal loslegen, wenn du
Okay.
willst. Mhm.
Well, thank you very much, Golam Reza and all your colleagues for the invitation to speak on this conference. And it's an honor for me, of course. I've actually been to Tehran in 2016 when I was the president of the International Schema Therapy Society, and I've been very nicely hosted there. And it's a beautiful country, beautiful people. And so I have a certain emotional connection with Iran. I've trained Iranian people, and so I feel very honored to be able to talk to you about schema therapy and its relation to hypnotherapy and to acceptance and commitment therapy. I will share my screen and show you my slides. I need the screen sharing rights, Ghulam Reza. I cannot share right now. You need to make me co-host.
Okay.
Yeah. Okay. Yeah, we forgot to double check that. Now I'm able? Yes. Here we go. These are my slides. I go to screen sharing mode. So now you can see the slides. It's about the essence. No, sorry, I have to go back to the first slide. I just added a slide a minute before the presentation started. This is the real slide. So what you can see here is it's a sculpture from the desert of Nevada. It's a huge sculpture and it carries the messages or the key message of schema therapy because the skeletons, the iron skeletons, are the person we are or we become over the course of life. And the concrete core, these little figures inside, this is what we regard as the child mode in our language, in our model. And it means they carry the needs of everybody. And on the level of our needs, we are very close to each other. We all need attachment. We all need a kind of security, a kind of assertiveness to express ourselves in life. And when we go back from these skeletons, from the presented personality, we call it on front stage towards other people, and we go inside to the heart of the people, the needs are still the same. As however old we get, we always carry the same needs with us, and they are shared needs with everybody. They are universal. So we try to connect people, especially when we work with couples, going back to your needs, and then you're much better able to connect with other people. And this is in this picture. So there are 3 steps in the development of schema therapy. The first step is the original model of Jeffrey Young, who developed that in New York, coming from from Aaron Beck's Institute in Philadelphia. He went to New York and worked a lot with personality disordered people, borderline people, narcissistic people. And he developed in the 90s of the last century, he developed a model based on schemas and schema coping. I will explain that in a minute. But it was kind of a cognitive and a kind of a rigid model. So when it comes to deal with these difficult personalities, Arnold Arndt in the Netherlands and in Germany, Gitta Jakob is the person promoting this model most. They developed a model for the studies very much based on the modes. And modes are the present moment presentation, the skeletons, the first image. And it's very close to an ego state model or parts of the self model. And there is a connection with hypnotherapy models. But the problem is that if you just look at the front stage presentation, the skeleton, you might lose the connection with the original schemas which have been embedded into the person in childhood, which is more a psychodynamic model. So we oscillate a little bit between these 2 models. And one of the disadvantages of the mode model is that there are so many modes that you can hardly distinguish them, and you might lose the overview. But the joint core of all schema therapy models is that there are frustrated core needs, the concrete part, that lead to schemas. Schemas are like internal working models of the self, of the world, based on the experience with your primary caretakers. And if the child needs were not met, this means these are painful experiences, painful memories, painful schemas. And to avoid the activation of these painful schemas, we develop coping modes to either sacrifice ourselves to stay connected with people if we have been abandoned. So we are overly self-sacrificing, overly internalizing, or we start fighting against the schemas. We try to be the top dog. We try to develop skills to express ourselves in the world. We might end up too much externalizing, or we develop a constrained lifestyle, become uptight, and stay detached from other people to protect ourselves. These are the 3 basic coping modes, and they lead to the front stage presentation in terms of modes. And that's the skeleton part, how we present ourselves to other people today. And since there might be a vulnerability schema, an abandonment schema, and we compensate the schema, we turn it into the opposite. And a person who is anxious to be left by others might become over-controlling and appears dominant on front stage, over-controlling, dominant, or self-aggrandizing to compensate the feelings of shame. They show up very much. They become narcissistic people. So the presentation on front stage might be the opposite of the vulnerable child feelings inside. And that's the problem, that there are so many modes that you can get lost in all these facets. And this is why we developed a 3rd step we call contextual schema therapy. And the contextual schema therapy incorporates 3rd wave ideas. You will hear about that from Johannes Michalak later today in the afternoon, after the lunch break. He will introduce an act or an mindfulness-based therapy approach, and you will find some of the bits I showed to you again in his presentation, because there's an overlap. We include these 3rd wave ideas, especially taken from acceptance and commitment therapy, and we merge it with the schema therapy model. So we use the process of disidentification from the schemas and the modes to take an observer stance towards all our emotions, beliefs, impulses to react. They are just object towards our observer self, which is a metacognitive perspective. Watch your thoughts, watch your emotions, watch your impulses to react, but don't go into that. Shift from a doing mode, acting things out, driven by an automatic pilot. Check out, go to observer mode, float above all your perceptions, your thoughts, your emotions. Try to connect with a broader contextual view on the world. Try to gain overview, go to a wise mind state, and do what's best for you, looking at your needs and your values. Where do you want to go in your life? This is the metacognitive perspective. But we need to accept that there are painful feelings, there are bothering thoughts, there are maladaptive impulses, maybe to drink or to develop compulsions or to restrain from people. This is the automatic pilot. Let it go. Accept it, but let it go. Look at the effects. That's functional contextualism. Don't base your decision on belief systems. Look at the effects. Does it make you feel better? Does it fulfill your needs? If it does, that's okay. And this is also act-based. And we try to regain psychological flexibility and overcome being stuck in automatic coping processes. These are key elements taken from acceptance and commitment therapy, embedded into the schema therapy approach. If you look, Jeffrey Young once defined the essence of schema therapy based on 3 columns or 3 essential parts. One is the therapy model, which means we base our work on schemas and we regard modes as the present moment presentations of schema activations. This is the core of our model, and I will go into that in more details in a minute. The second column is a very specific relationship, which is called limited reparenting, and it parallels the development of a client in therapy with the development of a child when it grows up. So at the beginning, we show kind of motherly reparenting skills. We are very active, we directive, we care for the client, we model behavior, we very much support them like good parents do. So this is the good reparenting part. We use self-disclosure, we show up as a real person, a tangible person. And in the second part of therapy, we go more to the limit setting part, to the empathical confronting part, like you need to do with growing up adolescents. You need to challenge them a little bit more, which is more the fatherly parenting style. Push them a little bit into autonomy. So we balance between these poles, but in a very active, directive way. Even compared to hypnotherapy, we are even more directive, more prescriptive. And the third column are the experiential techniques. They are basically taken from Gestalt therapy. And there's a huge overlap with hypnotherapy techniques, like doing work in imagery. We work with separate chairs. We split a client up on 2 chairs, for example, one for the belief system, one for the emotional reactions in the body. And then you can play the conflict between the beliefs, the pressuring beliefs, and the stressed emotional side. You can play it out as if this were 2 people. And these are Gestalt therapy techniques, but we try to use them in every session to avoid ending up talking about things, because we want to reach the emotional experiential level, the episodic processing, and this is where images guide us to. The basic model contains 3 elements. On the top line, you see the starting point where schemas come from frustrated core needs. And the frustrated core needs, when the schema is triggered today, they show up as negative emotions, as basic emotions felt in the body, in the polarity of a vulnerable side and an angry side. These are the 2 emotional trajectories. And on the other side, the messages given to the child get internalized, end up in an internal working model about the world, and they got stored in core beliefs, like in CBT. This is our belief system. And the belief system is accessible as the voices in the head. If you ask a client, close your eyes, what is the voice in your head telling you right now? They frequently respond, they tell me, you have to be better. So the client actually shifts the wording into a second person language as if another person is talking to them. And this other person's voice is the origin, the root of these beliefs. And we try to re-externalize these voices in therapy again. And based on these two schema-based elements in the body, the emotions in the limbic system, in the body system, and the beliefs in the cortical areas, they both come together. They get merged together in the orbital frontal cortex, in the anterior cingulate cortex. And this is where both roots are merged into a behavior. And these backstage processes show up on front stage as the displayed behavior, the displayed modes. And these displayed modes are presented in a polarity between more internalizing behavior, which we call the blue side, and more externalizing behavior, which we call the red leg, the red side. So if you look at the emotions, they show up in a polarity between vulnerability, blue side, fear, sadness, vulnerability, the vulnerable child, and in a more sympathetic driven, activated, annoyed, angry side, when the sympathetic branch comes in, and this is the red side. So the emotions show a polarity between vulnerable and angry, and the core beliefs are also more self-critical or more critical about others. You should do better, or you deserve a better treatment from them. So beliefs are also kind of polar in this spectrum between the tendency to internalize or to externalize. So we end up in triangles of emotional activation and belief activations backstage, more on the vulnerable side, more on the externalizing side, beliefs as well. So it comes together on the triangle in the skeleton reaction displayed to others in this spectrum, like it is described in DSM-5. This is the polarity of externalization, internalization. And the therapy process is don't go into the coping mode, stop coping behavior, disidentify, diffuse, connect with emotions, accept them, get aware of your core beliefs, but diffuse from them, look at them from the outside, from the healthy adult mode, from the observer self, and then you can moderate and regulate, perceive and regulate and moderate the emotions, and you can reappraise and eventually impeach dysfunctional beliefs. This is the healthy adult mode job. And this leads to behavior in the same spectrum between blue and red, but in a more moderated, balanced, and flexible application, not stuck in rigid coping modes on the bottom line, but in a more flexible balancing between more cooperation, not surrendering, but cooperating, which is also blue, and not dominating, but being persistent, showing your stance and show a kind of assertiveness, healthy assertiveness, and to be able not to emotionally detach from things, but let things go, diffuse, stay away from over-identification of your internal activations. So the spectrum is the same between internalization and externalization, but the healthy adult mode is much more centered, more balanced, and more flexible in riding the tide in a centered way. If you look at the dysfunctional act processes, they are all based either on getting stuck in coping modes or being over-identified with maladaptive beliefs or values, critic voices. So what we try to do is to overcome these maladaptive processes. And I show you in the next, because they lead to psychological rigidity, getting stuck in automatic coping modes. And what we do is that we add the layer of the healthy adult mode. You already saw it. We need to go into a mindful state first. Johannes Michalak will tell more about that. Going to observer mode, check out from the doing mode, go into a being mode, get aware of your emotions, accept emotions, diffuse from critic voices, go into mode awareness. That's the first step. That's the A, mode awareness. And then you're able to stop automatic coping, go into being mode. Everything's there, everything's okay, but it's not you. It's just an emotion, it's just a thought, it's just an impulse to react. It's not you. You are the observer. You're here in your core. This is your core. And you don't have to act out without mindfulness. In a mindful state, you can connect with your needs and values. You can connect with the concrete core part within yourself, your core self. And then you might add perspectives in a contextual way that help you to realize that these voices are not helpful. And then you might let them go. That the emotions are just emotions. What does it take to get better in your life? Which direction do you want to take? And so you go to mode balanced from an overview perspective. That's the B. And from there, you can choose what reaction, which mode offers you the best, will promise you the best result. That's the C, that's the mode choice. And this gives you back your reaction flexibility. So you need to check out first, shift the gear out first. If your car gets stuck, you shift the gear out, go to observer mode, and then you regain overview. You might ask yourself, what would my best friend do? What is the therapist adding to the table? What would you do if this was your child feeling these feelings? And we activate resources from the observer perspective, which are not accessible in the doing mode, but in the being mode. When you stand up and go to an observer stance, we literally stand up. I would show you that in the last minute of my presentation. We stand up to actually regain a physical overview on the emotions and the beliefs on the chairs. I'll go there in a second. Can you still hear me?
Yes.
Okay, because sometimes when I pull the cord, it gets disconnected, but glad to hear that you still hear me. Okay, so this is the shifting gear out, choosing the best gear and shifting the gear in movement to a healthy adult and back to behavior. And if you connect it with the acceptance and commitment therapy, there's open mode awareness, centered mode balancing, and engaged committed action. These are the same elements. All the words in italics are from acceptance and commitment therapy. So you see the merge between acceptance and commitment therapy and schema therapy. And now I'm coming back to the techniques and more details of the therapy relationship. I already mentioned that we use body postures to help the client to change their perspective. So on one axis, we oscillate between a schema activation in imagery, and this is performed by closing your eyes, connecting with the body feelings, going in, get away from all your perceptions, go into your body, allow yourself to float back in time along the affect bridge with the emotions, and then immediately images will pop up which have the same emotional structure that is activated by the current triggers. So we use the present moment perceptions as the trigger to activate schemas, and we float back to connect with the schemas. This is imagery position. This is when we connect with the past influences into our present moment. But this is dragging us into these emotional states, into the doing mode, into these processes. And then we need to be able to stand up, to check out, to go into observer position, to watch the feelings and the thoughts inside of ourselves as an object popping up on our mind. And this helps to disidentify from the emotions, from the beliefs. And we actually do it in a standing up position together with the client. So we start the session, and I'm going to change. Now I complete the slide first, and then I change the camera. The second axis we are working on One is experiencing mentalization. No? Episodic memory processing, semantic memory processing, building up a functional narrative to the emotions. This is the vertical axis. And the horizontal axis is we trigger the schemas in the confronting position. And this is either another person or in imagery, the mother, the father, an offender, but it could also be the critic voice of the client. Everything that triggers the schemas is put on one chair. And on the other chair is the experiential self of the client. And I want to take a turn of an imagery rescripting session with you now as the last step of my presentation to show you how we move between the positions. And we ask the client, when we sit with the client, I change the camera now. I guess I need to stop the screen sharing first to change the camera, and I can actually, you remember these 4 positions, and I keep the slide big so you can see the slide. Yeah. But this, yeah. You wait, maybe I can focus myself. Yeah, so you see me a bit bigger now, I guess. I'm here. This is the client. Let's call her Betty. Let's call him Tom. This is Tom, my client. And I'm sitting here. I start the session on my chair, and I have an additional chair. I start on my chair and say, hello, welcome to our therapy, Tom. What did you bring to the session? And he might say, yes, last week I felt so bad. I didn't perform at the job, and my boss criticized me, and I felt so bad, and I'm afraid they're going to kick me out. I say, okay, we are not talking about it. We go into experiential work right away, within 1 minute or 2 minutes or 3 minutes. And then I sit with the client in the supporting position. Remember, supporting position. And I invite him, okay, close your eyes. Bring up the image of your boss. How is the boss? And the boss is over there on the other chair. How is the boss looking at you? Look at his eyes. Can you listen to his voice? You listen to his dismissive wording. And you can feel the atmosphere in the room, the vibrant atmosphere. Okay, how does that make you feel in your body? Connect with the feelings in your body. Is your chest getting wider or tighter? Is breathing easier or harder? Is there a more crampy or more flaw feeling like fainting in your belly? Do you feel powerful so you could expand, or do you feel weak, like falling apart, like breaking down? So we offer polarities of a more sympathetic externalizing state or a more vulnerable internalizing state to give clients a handrail to connect with their emotions, because it's much easier for them if you offer them a little bit. And once he connected with the body, we ask him, okay, what images pop up? Stay in touch with the feelings, float back in time, and just get aware which images are coming. And then he might see the father scolding him when he was not okay in school, didn't bring good remarks. And I ask him, okay, how do you feel towards this father? Can you see the father? Yeah. How does it make you feel in your body? Oh, I feel so devastated, so weak, so bad. Nobody needs a person like me. That's the thought. Okay. And what is your impulse now? Oh, I just want to hide. Yeah, that's what you did. You duck and covered. That's the diagnostic part. And now we ask for the need, the concrete core. But what do you need as a child when you just bring a bad remark and you feel so flawed, so bad? Yeah, I need somebody to support me, to protect me, to help me a little bit, to perform better. Yes, you're right. You as a child, you couldn't do anything. You need somebody supporting you. And in one script that we use in imagery, we now would stand up to go into this observer position. Wait a second. And from the observer position, we are able to look from the outside. We ask the client, now you are the adult person this boy needs. And Tom, if you look at this father, how he pressures the boy, if you look at the effects of his expectations, they might not be wrong, If you don't learn in school, you will not perform in life. But how does it make the child feel? It's devastating. It's disempowering. It gets weaker. He gets hopeless. This is not a good effect. What do you feel in your body if you look at this father beating the child up? Oh, it makes me angry. And that's the resource, to turn the anger towards the overshooting expectations of the father, and maybe tell the father, you're not helpful. Whatever you intend, you're not helpful. We're going to replace your messages by adult messages to the child. And then you offer messages. You will do your best. We'll do as good as we can. We will take one step after the other, and then we'll see where we end up. Just healthy, supportive, good parent messages to the child. And at the end, the client sits down and we ask him, okay, how does it make you feel now in your body when you see how this adult part, supported by the therapist, care for you? And they hopefully get better, and they hopefully internalize these voices, and we record these voices so the client can listen to the tapes at home and internalize the good therapist, the good adult mode, and replace the messages of the internalized objects, the father, with these beneficial supportive voices. This is the idea of the therapy. Yeah, I covered my time, so there are a few minutes left for questions, and I stop here. I just go to screen sharing again to show you where you can find more information about that, which is our website. And the book is published in Farsi, as far as I know. You can ask Amir Askari. I guess he cared for the translation. And if you go to this website, schematherapy-rodiger.org, you see a lot of tapes, a lot of resources, instructions, slides. There's a lot of information, so you can go there for more information. Yeah, thank you for your patience, and maybe there's one or two questions left if we have the time. Well, is there anybody? Ghulam Reza, can you hear me?
Ja, ich höre
Okay.
dich schon jetzt. Ich versuche mal jetzt mit der کامera jetzt wieder reinzukommen. اگر که سوالی چیزی دارید میتونید بگید که من میتونم، اگر که میدونید انگلیسی نمیخواید بگید میتونم من ترجمه کنم که بگم بهشون. اگر که میخواید به فارسی بگید. Ich habe gefragt, ob es mal schon einfach auch dann Fragen gibt.
Ja. Du entscheidest über die Zeit, ne? Weil wir sind jetzt eigentlich schon am Limit.
Ja.
سلام، من میتونم سوالم بپرسم؟
میخواید خودتون به انگلیسی بپرسید؟
میتونم به انگلیسی بپرسم، میخواید من فارسی بگم شما ترجمه کنید، فرق نمیکنه.
نه شما به انگلیسی بپرسید، خواهش میکنم. Hörst du dann schon der Teilnehmer, der fragt jetzt?
Ja, aber das war ja Persisch.
Ja, das ist Persisch. شما دست به انگلیسی بفرمایید.
Okay. Hello. Thanks a lot for your presentation. My question is about strengthening the observer mode. I mean the healthy adult mode.
Yeah.
Can we strengthen the healthy adult mode by hypnosis techniques? I mean, can we hypnose the client and strengthen the observer mode to can deal with more easily?
I don't know. To be honest, it might work because you can do a lot of things with the brain. For us, we try to use the body resources. So the position change to stand up physically changes your body activation. You feel more adult, more assertive, more flexible. You can move better in the standing position compared to being trapped on your chair. This is more a child position. And this is an adult position. So we try to get support from the body to shift into another brain activation. You might do it based just on imagery, on hypno strategies. But we think using the body, it's just like with a violin. You pull a string, but the body of the violin or the guitar resonates and makes the sound stronger. So we try to have a very integrative therapy involving body movements and body activations.
That makes sense. Thanks.
Yeah. Thank you for your question.
You're welcome.
خیلی ممنون. سوال دیگه ای هست؟ Also, anscheinend keine Frage mehr und herzlichen Dank.
Ja,
Dann,
Golamesa.
das ist ja schon einfach auch dann toll. Vielen Dank für deinen tollen Vortrag.
Gerne.
Und hoffen wir mal schon, dass wir dich da schon immer öfter da schon in unsere Kongressen
Ihr könnt euch gerne wieder melden. Und
Ja.
euch eine gute Tagung. Everybody, a beautiful conference. I'm glad that you're able to do it in these difficult times. And I wish you a lot of good information and a great conference. Thank you for the invitation. Okay, all the best for you.
Dankeschön. Danke
Bye bye.
und bis bald. Tschüss.
Bye
Ciao.
bye.